Thank you for selecting our abstract for a verbal presentation. My name is Hidde Kroon and I'm presenting on behalf of Charlotte Keupens and the other investigators of the Colorectal unit from the Royal Adelaide Hospital. Our study is called Feasibility Study of a New Opiate Scarce Modifiable Enhanced Recovery After Surgery Protocol to Avoid Postoperative Opioid Use. We have nothing to disclose. The last few decades have seen an increase of opioid prescriptions and more chronic opioid use. ERAS protocols can tackle this problem. In May 2018, the Royal Colorectal unit has started a modifiable ERAS protocol with a focus on opioid scarce pain management. In this, we moved away from postoperative opioids and provided multimodal analgesia alternatives such as TAP catheters, pregabalin and tramadol instead of oxycodone or other opioids. The aim of the current study was to evaluate this modifiable ERAS protocol on postoperative opioid use. The methods: a retrospective single-center study comparing two cohorts at the RA, one original ERAS protocol and one modifiable ERAS group. We included all patients who underwent elective colorectal surgery. Primary outcome was duration and quantity of opioid use. Secondary outcomes were time to passage of stool, tolerance of diet, length of stay, complications, and 30-day readmissions. Then the results. The patient characteristics were equally distributed between both groups. There was a slightly higher percentage of smokers in the modifiable ERAS group, but this was not statistically significant. Also, the perioperative results were similar between both groups with similar operation types, surgical approach, and stoma formations between both groups. Then the primary outcome, the postoperative analgesia use. Fewer PCAs were used in the modifiable ERAS protocol group, whereas wound pain catheters such as the TAP block were used significantly more in this group. Postoperative opioid use was significantly less, but still 88% of the patients received opioids. However, we moved towards the weaker opioids such as tramadol, and fewer patients received oxycodone or similar. Also, the duration of the opioids was significantly reduced. And lastly, the NSAID use was increased, as this is part of the modifiable ERAS protocol also. Then the secondary outcomes. These were similar between both groups, but one thing: pneumonia occurred more frequently in the modifiable ERAS protocol group, for which we have no real explanation. Apart from that, there were more smokers, as I showed a few slides ago, in the modifiable ERAS protocol group. So in conclusion, significantly less opioids were used in the modifiable ERAS group with a shorter duration of its use. More analgesia alternatives were used, such as NSAIDs and tramadol. However, it was not yet significant to improve clinical outcomes as shown in our secondary outcomes. And we are investigating why pneumonia was higher in the modifiable ERAS group, if this is true or by chance. Thank you very much for your attention.